Thank you very much to UICC for inviting me to moderate this session. Thank you to the sponsors. This has really been a tremendous meeting, and I'm looking forward to the discussion that we're going to have here. Why do I get the privilege of moderating this panel? I think because I've been nagging at people for many years to seriously discuss financing for non-communicable diseases globally, and we're going to discuss that today. We're also going to discuss what we can learn from a completely different sector, from the climate change actions that cities have been taking around the world to address climate. We have a lot to learn in the health community from other sectors, and so we have some very good examples of what's been done and how we can apply it to our challenges with cancer and with NCDs broadly. So with that, first I'm going to invite, well, first let me introduce. Let me get my notes out for that. I'm going to introduce the session. It's been billed as a learning session. So in the short space of 1 hour, what are we going to learn? We're going to learn how mayors working together can actually change the world for the better. We're going to learn how to tackle two enduring challenges that we face with NCDs and with cancer. As I mentioned, understanding and learning how to work with other sectors, with non-health sectors, and also learning about what works in financing and how to support and mobilize more financing for cancer and for NCDs. So mayors have been using the C40 network to address climate change, and we look forward to hearing examples from our first speaker of what's been done in that area. And then we will learn from our other speakers some of the challenges of financing and of addressing cancer from a city perspective. So let me start by inviting our first guest, the man who is in charge of health in this beautiful city, Dr. Armando Ahued. Dr. Ahued, I'm not sure where he is sitting. There he is. Please join me up here. We're going to sit and have a discussion. Dr. Ahued is a doctor. He is the Minister of Health of Mexico City, which he's been in that role for 8 years. He's dealt with many health issues, flu epidemics, the right to health, and of course earthquakes. You've dealt with a lot of health issues, a lot of city issues. And I'm going to ask you to tell us a little bit about the C40, which is an initiative of mayors to address climate change, and tell us about Mexico City's experience with that and what is working, please.
Muy buenos días a todas y a todos. Muchas gracias, Rachel. El jefe de gobierno, el doctor Miguel Ángel Mancera, pide disculparlo de no estar aquí como era su deseo. Sin embargo, está en este momento atendiendo la emergencia de la Ciudad de México, el tema de la reconstrucción después de los sismos, y me ha pedido representarlo en este sentido. Primero, me da mucho gusto y bienvenidos a la Ciudad de México todos y todas, todos los que luchamos contra el cáncer en el mundo, y sin lugar a dudas será una gran experiencia. Y hablando específicamente sobre el cambio climático y lo que ha hecho la Ciudad de México, el jefe de gobierno, el doctor Miguel Ángel Mancera, ha impulsado y trabajado en el grupo de C40. ¿Y por qué? Porque el cambio climático está teniendo un efecto muy importante en el mundo. Las grandes ciudades de todo el mundo son los que generan el 70% de la contaminación, y más del 50% de la población en el mundo vive en las grandes ciudades, y se prevé que para el 2050 el 70% de la población del mundo viva en ciudades. Por lo tanto, desde ahora es muy importante que las ciudades ejecuten acciones para tratar de mitigar el tema del cambio climático, y la experiencia del C40 ha sido muy importante. El compromiso de París lo que está pretendiendo es que no se incremente más de 1.5 grados centígrados el calentamiento global. Y estamos viendo ya que los efectos de la contaminación están teniendo ya impacto en las grandes ciudades y en el mundo. Estamos viendo que llueve con mayor frecuencia, está ocasionando problemas serios, inundaciones, por supuesto el cambio, la afectación del tema de calor, olas de calor que también provocan que no haya agua en las ciudades y que haya incluso afectaciones a la salud. Por ejemplo, pues la aparición de algunos vectores que permiten la transmisión de enfermedades como el dengue, el Zika, el chikungunya, y que de alguna manera están teniendo afectaciones, por ejemplo, los niños, las embarazadas, los adultos mayores, en ese sentido. Por lo tanto, me parece que la experiencia del C40 podía ser muy útil para este evento como una manera de intercambiar experiencias entre las grandes ciudades de lo que hemos estado haciendo en las diferentes partes del mundo e intercambiar experiencias. Por ejemplo, la Ciudad de México ha implementado rutas de prevención en el tema del cáncer. Ayer lo comentaba en mi presentación, que es un problema multifactorial que debe ser abordado, primero que nada, con un compromiso de los gobiernos, dándole una visión de que no es una responsabilidad solamente de las secretarías o ministerios de salud, sino es una responsabilidad social, es una responsabilidad que implica a las familias, a las escuelas, a los maestros, a la sociedad en su conjunto, y que debe de abordarse con educación. Yo celebro que una de las partes que más me ha dado mucha alegría es que todos estamos apostándole a la educación en salud, empoderar a la gente del conocimiento, de los estilos de vida saludable. Vemos que muchas de las condiciones del cáncer están vinculadas precisamente con factores como la mala alimentación, como la falta de ejercicio, como las adicciones, el tabaco, el alcohol y, por supuesto, el no tener una corresponsabilidad en el autocuidado de la salud. El gobierno puede poner mastógrafos, puede hacer pruebas de Papá Nicolau, pero si las personas no van a hacerse la detección oportuna, pues llegan tarde, como hoy está pasando. De cada 10 personas con cáncer, 7 llegaron tarde. 7 llegaron cuando ya hay metástasis, cuando ya poco se puede ofrecer. Y el sistema de salud no aguanta, está recibiendo más gente enferma, porque hoy vemos niños con afectaciones, leucemia principalmente, pero también mujeres y los hombres con cáncer de próstata. Miren, ejemplos, en la Ciudad de México, de 1990 a 2015, el índice de mortalidad se elevó 44%. O sea, es un desafío y un reto para la salud en nuestra ciudad. Y por supuesto, el tema de cambiar esa cultura de detección oportuna. Por ejemplo, en mastografías, de cada 3 mujeres que debieran hacerse una mastografía, solo una se lo hace. En el caso de Papá Nicolau, de cada 2, una se lo hace. Y en el caso de cáncer de ovario, una de cada 10 se hace un ultrasonido. Y en el caso de los hombres, 1 de cada 10 se hace un antígeno prostático. De tal manera que en la Ciudad de México lo que hemos implementado es estrategias, por ejemplo, la ruta de detección para el antígeno prostático, un tamizaje en toda la ciudad, preguntando si hay algunos factores de riesgo y entonces les hacemos antígeno prostático. Era algo que no se había hecho nunca en el mundo, incluso debe andar por aquí uno de mis queridos amigos, exdirector de cancerología, y me decía, en el mundo nadie ha hecho un tamizaje abierto porque es muy complicado, sin embargo lo hicimos y hoy le salvamos en un año a 198 hombres la vida porque llegaron a tiempo por haberse hecho este antígeno prostático con 3 gotitas de sangre. Y en el caso de las mastografías, el jefe de gobierno, el doctor Mancera, ha impulsado mastógrafos, unidades móviles que andan en toda la ciudad haciendo mastografías gratuitamente. Y el Instituto de las Mujeres promoviendo que vayan a hacerse el chequeo. En cáncer de ovario acabamos de lanzar una estrategia de detección porque es de los cánceres más agresivos y más difíciles de diagnosticar. Siempre se confunde con problemas digestivos y colitis y otras cosas y es muy difícil de diagnosticar a tiempo. Por lo tanto, a mí me parece que la experiencia del C40, donde hay un intercambio y compromisos de diferentes ciudades y países, pudiera ser un mecanismo de compartir las experiencias exitosas de lo que cada quien haya hecho y, por supuesto, replicarlo. Así que sí considero que es una gran oportunidad de crear un C40, pero en el tema de cáncer, en donde las grandes ciudades y todo el mundo participe con iniciativas, haciendo partícipes, por ejemplo, a las mujeres que nos digan cómo pudieran acceder a los servicios o acceder a la prevención. Y yo creo que tenemos que seguirle apostando a la educación. El C40, lo que en el tema de contaminación ha sido muy bueno, porque está creando compromisos gubernamentales y estrategias que sí están caminando. Por ejemplo, el tema de evitar ya para el 2025 el transporte con diésel. El tema de hacer acciones con biodigestores para que pues, no se contamine más, incluso esa energía sirva para evitar que las gentes que guisan con leña puedan hacerlo de manera con otra fuente de energía. Y yo creo que el C40 y este compromiso que han mostrado los alcaldes ha funcionado, ha permitido que cada uno aprendamos de los demás y también los demás de nosotros. Tenemos en la Ciudad de México un programa que se llama El Médico en tu Casa, que hace 3 años el doctor Miguel Ángel Mancera hizo realidad y hoy nos da mucho gusto que lo hemos compartido con países como Cuba, Guatemala, Panamá, Uruguay, Brasil, Argentina, Ecuador, París, Madrid, Kuwait, Dubái, Lituania, 3 provincias de China. Y yo creo que ese ejemplo nos permite que se difundan las acciones y las políticas públicas que han funcionado y mejorarlas, por supuesto.
Thank you so much. That gives us a thank you. Very rich set of examples of. I'll wait just a moment. Set of examples of how the exchange among mayors with C40 can be applied to CCAN. And I know you've spent a lot of your professional position, your time in this position, thinking about health literacy, and now we're hearing how you have acted upon it and how you see the effects on people seeking care and on getting diagnosis and getting tested. I'm wondering if you can give us an example of how that has been applied elsewhere, from your discussions with mayors elsewhere. Have you been able to see the ability to have that information exchange and that knowledge exchange to help them think about how to increase health literacy and increase the awareness in their populations? Have you seen this happening?
Sí, sin duda hay que concientizar a la población de los problemas, tanto en la contaminación como en el cáncer. Decirle a la población lo que está ocurriendo y cómo deben de participar, porque así como el cáncer no es solo una responsabilidad del sector salud, tampoco la contaminación es del gobierno. El gobierno forma parte y es muy importante su acción, pero las políticas públicas se tienen que trazar que sean viables, que sean factibles y que la gente las adopte, que la gente participe, porque cualquier política pública donde no está involucrada la gente, donde no hay un compromiso, no van a funcionar. Y yo creo que en el C40 ha habido acciones que han desarrollado otras ciudades o países en el tema de contaminación y que sí se han intercambiado entre los alcaldes estos grupos de trabajo, qué ha funcionado, qué no ha funcionado, qué es más difícil de implementar. Cada uno de acuerdo a su nivel socioeconómico, ciudades que tienen un potencial económico pueden hacer cosas más rápidas, otras ciudades con menos capacidad es más complicado. La conversión del transporte eléctrico a lo mejor es más difícil, o la construcción de más metro. En fin, tratar de ver, de acuerdo a las posibilidades de cada país, qué acciones pueden desarrollar. Y yo creo que en el cáncer igual, por ejemplo, cambiar estilos de vida. Estamos hablando de algo muy complicado, el comer bien, el alimentarse adecuadamente, el evitar la comida industrializada, el tema de la educación para tomar acciones de detección oportuna. Yo creo que la educación en salud es uno de los puntos que más nos va a ayudar, tanto en el tema del cáncer, por supuesto, como en el tema de la contaminación. Pero sí hay grupos de evaluación de las ciudades para ver qué está funcionando, qué no está funcionando.
Thank you. I'm glad you spoke about evaluation, because I think it's one of the things that, of course, Mexico is very well known for doing an excellent job of evaluating its programs, understanding what works and what doesn't work, and I think that's something very important for the CCAN effort, and clearly also for C40. So that's, I think, a very important thing that many cities and even countries can learn from the Mexico City example. climate change is a really big problem, and so is health, so are non-communicable diseases. And it seems almost overwhelming to tackle those at any level, whether it's the city or the whole national level. And I'm wondering, because we speak about political will, and we often speak about how politicians, they hesitate to take on hard problems, they hesitate to take on things that will show reward many years in the future, because they have a short tenure often. So tell me a little bit about how the political will in Mexico City is created. It's clearly there, and it's clearly there also with your national government and your president. But maybe you could speak a little bit about how that helps your job to know that they are behind you.
Sí, cómo no. Miren, les voy a dar 3 ejemplos. El primero fue, en este gobierno de la Ciudad de México, nos atrevimos a vacunar a las niñas contra el virus del papiloma, el precursor del cáncer cervicuterino en las mujeres. Cuando propusimos que se hiciera, todo el mundo dijo, no es posible, no se puede. Y nosotros dijimos, sí se puede. Y se trazó una política pública en la cual todas las niñas de la Ciudad de México de 9 a 11 años fueron vacunadas contra el papiloma humano. Y fue una política local por una voluntad política. Y 4 años después, el gobierno federal de México decidió que se hiciera una política nacional. Y hoy es una política de mucho éxito. Pero 4 años tardó en que esta voluntad política y este ejemplo creciera a nivel nacional. Y quiero decirles que la pregunta de todo el país era, ¿por qué a las niñas de la Ciudad de México sí se les cuida y se les previene para el cáncer cervicuterino? ¿Y por qué a las niñas de todo el país no? Y empezó a hacerse una presión, hasta que finalmente se hizo 4 años después. Y hoy es una política que está en todo el país y que nos atrevimos a hacer. Segundo ejemplo, hicimos la ley 100% libre de humo de tabaco. En este país mueren cerca de 78,000 personas al año producto del tabaco, principalmente cáncer. Evitable sí, pero hoy vemos que nuestros niños empiezan a fumar a los 9, 10, 11, 12 años. Necesitamos la intervención de los padres, de las escuelas, concientizar del problema del tabaco. Y nos atrevimos a ser 100% libre de humo de tabaco. La oposición era muy fuerte, obviamente de las tabacaleras, pero también de los restaurantes y bares. Decían, la gente no va a venir porque no puede fumar. Y nosotros dijimos, vamos al 100% y no permitimos afectar a los no fumadores. Y también le bajamos al consumo de los fumadores, por cierto. Y es algo que hicimos en la Ciudad de México. Y hoy la política nacional es 70-30, 70% no se fuma, 30% sí se puede. Y nosotros en la Ciudad de México tenemos ya casi 10 años con la ley 100% libre de humo de tabaco. ¿Qué quiere decir? Que cuando hay voluntad política y cuando hay decisión de proteger la salud de la población, lo hacemos y lo llevamos a cabo. Otro ejemplo. En 2009 tuvimos la aparición de la influenza, el H1N1. La primer pandemia del siglo, un virus desconocido, no había antirretroviral, no había vacuna, no sabíamos la letalidad del virus y no podíamos realmente tener la consecuencia que podían haber muerto cientos de miles o hasta millones de personas. No fue así, afortunadamente, pero tuvimos que tomar una decisión, cerrar la Ciudad de México, cerrar los lugares públicos. Y era para proteger a la población. Yo creo que cualquier acción de gobierno que tienda a proteger la salud y la vida de la gente es viable y es posible. A veces son decisiones muy complicadas, pero yo siempre he pensado que un gobernante que no toma decisiones no sirve para gobernar. Y mientras esté pensando siempre en salvaguardar la salud y la vida de la gente, eso es lo más importante. Esa es nuestra misión, mantener la salud de la gente, no estar atendiendo enfermos. Por eso el modelo de salud de la ciudad es diferente. Ya no es reactivo, sino es anticipatorio. Tenemos que trabajar para mantener sanos a los sanos el mayor tiempo posible. Detectar oportunamente a los enfermos y atender a los enfermos y contar con la infraestructura necesaria para poder atender. una persona con cáncer ya no le podemos decir es que solo vemos lo preventivo. No, ni modo, ya hay que atenderlo. Pero yo creo que el gobierno tiene que tomar medidas y tomar decisiones, a veces muy difíciles, pero yo creo que es parte del compromiso que tenemos los servidores públicos.
Again, thank you so much. You've given us 3 excellent examples of where political will has made a real difference to people, and I think you've also given us a hint that a little bit of competition is not such a bad thing, that other cities in the country and other cities elsewhere see what is being done here, see that it works, see that you're taking some brave steps, and then they want to follow. And their citizens want the same thing. So I think those are both 2 good examples. I'm going to give the audience a little aviso that I will take a question or 2 from the audience. Before we do that, though, perhaps one more from me. And thank you for taking so many questions. Can you give us maybe one example from the networking with other mayors that the C40 has led to that directly applies to your challenges with cancer and the CCAN challenge? What lesson, what experience, what connection that you've had through C40 directly allows you to make progress with CCAN?
Sí, por ejemplo, el jefe de gobierno entró a la iniciativa de transporte libre de diésel hacia el 2025. Hay un compromiso de las ciudades para ya en 2025 dejar de utilizar transporte con diésel. Ese es un compromiso ya para el C40, y en esta cumbre se reunieron alcaldes de más de 20 ciudades y representantes de 50 ciudades del mundo, en las cuales ya se asignaron y ya se comprometieron a llevar a cabo esta acción. Y por supuesto, obviamente el diésel y la contaminación por diésel tiene un efecto incluso sobre el tema del cáncer. Otra acción es el llamado fecha límite 2020. 8 ciudades piloto se comprometieron a hacer iniciativas y que se orientaran los esfuerzos para programas de acción climática. O sea, 8 ciudades, y estamos hablando de la Ciudad de México, París, Londres, Nueva York, Chicago, Los Ángeles, Durban y Sydney. Son ciudades que se comprometieron a ser podríamos decir, programas pilotos de acciones y compartir resultados con los demás. Y yo creo que también aquí en el cáncer se podían hacer que algunas ciudades, 8 o 10 ciudades, pudiéramos hacer este ejercicio, un programa piloto en promoción, prevención, detección, campañas. Yo creo que sería muy útil que pudiéramos hacer este ejercicio y compartirlo ¿con quién? Con todo el mundo, y que pudiera ser resultado de esta situación. Pero en C40 está funcionando muy bien este programa de Deadline 2020, y pues fue un acuerdo en París, fue un acuerdo que se logró con 8 ciudades piloto. Y por supuesto hay un programa que se llama Tutoría de Mujeres en el Clima en el C40 para apoyar el talento y la innovación de mujeres y generar soluciones climáticas. Aquí, desde la Ciudad de México, varias mujeres van a presentar proyectos de mitigación y adaptación al cambio climático, y los mejores 10 proyectos de mujeres serán apoyados a través de capacitación a nivel mundial. Yo creo que podíamos lanzar una iniciativa desde este gran foro para que las mujeres participen en el tema, y yo diría incorporar estas ideas que pudieran tener para hacer acciones en el tema de cáncer.
Muchísimas gracias. I don't have a clock. Oh, I do have a clock. And I think we have time for 1 or 2 questions if there's someone from the audience, and I think there's probably some roving mics. So yes, please. Yes, she's right behind you with the mic. Turn it on.
Aló, aló. Sí, yo soy Armando, cirujano oncológico de la Fundación y Prevención para el Tratamiento del Cáncer. Una pregunta específica es ¿cómo hace México para que una actividad o una política que ha funcionado, el siguiente grupo político que venga esté en desacuerdo y la destruya, que se mantenga, ¿cómo hacen para mantener algo que ha funcionado lo suficientemente fuerte para que no sea pues, dañado después, ¿no?
Bueno, su pregunta es muy importante porque yo creo que lo que hay que hacer es blindar las acciones. No puede de un gobierno a otro cambiar la política. Yo creo que la política que vaya en beneficio de la gente debe de continuar. Sin embargo, tiene razón. En muchos gobiernos se llega y dice, ¿cómo vamos a continuar lo que hizo el gobierno anterior? Vamos a hacerlo bien y vamos a hacerlo nuevo. Y se pierde toda esa experiencia, se pierde todo ese trabajo. Y en el caso de la Ciudad de México, en varios programas, el jefe de gobierno lanzó estas iniciativas de ley para hacerlas ley, con lo cual garantizas que continuarán estos programas. Y un ejemplo es Médico en tu Casa. El Médico en tu Casa es una estrategia que el doctor Miguel Ángel Mancera, el jefe de gobierno, ha hecho ley. Con el apoyo de los diputados ya va a quedar para siempre. Ya vendrá otro gobierno y no podrá quitarlo, a menos de que todos los diputados votaran que hay que bajar esa ley. Pero cuando una ley tiene un beneficio sobre la gente, pues la gente lo va a defender y va a decir, ¿cómo me vas a quitar este beneficio? Y yo creo que muchas de las acciones se podrían convertir en ley para evitar precisamente la tentación de que un gobierno diferente llegue y diga, esto va para atrás y vamos a hacer ahora otras cosas nuevas. Pero yo creo que en salud yo me atrevería a decir que es de las áreas que más se respeta, porque en 6 años o en 10 años volveremos a tener una cumbre y estarán, esperemos que estemos la mayoría otra vez, y esto no va a cambiar. Al contrario, está cambiando para aumentar el problema del cáncer, y lo que tenemos que hacer es trabajar. Como ayer lo decían, iniciamos tarde y tenemos que darle velocidad, tenemos que acelerar el paso. Y yo creo que todas estas acciones se tienen que reforzar y que no sigan un camino independientemente de las personas, que sean institucionales, que sean compromisos de los gobiernos y no de las personas, sino que sean compromisos en beneficio de la gente.
Gracias. I think you have explained very nicely how you, Dr. Ahued, and Mayor Miguel Ángel, etc., have really harnessed the people power that was spoken of last night by Mr. Taboo, the people power to bring about the political will and to sustain that will to make improvements in the city. I'm going to thank you very much for joining us and for the really interesting answers I think we can all take some lessons from for the CCAN Challenge. And thank you for what you're doing in Mexico City.
Muchas gracias, muy amable.
Gracias. All right, some very good examples to learn from. We're going to turn to our topics that are, again, discussing some of the non-health sector challenges, as well as some of the financing. I'm going to invite up to the stage our next speaker, our next guest, I should say, Dr. Chertorivski. Yes, here he is. Dr. Chertorivski is the Secretary of Economic Development in Mexico City, but also has been the Minister of Health for Mexico. And so we're going to take advantage of his experience. Hello, very nice to meet you. His experience in both of those roles. Have a seat. And I'm going to first, we'll talk about city economic development and what that has to do with health in just a moment. But first, I'd like to have you put on your hat of Minister of Health for Mexico. And I'd like you to talk about what were the advances in the health system during your tenure that especially have addressed cancer and what we can learn from those, and then we'll go to the city level.
Okay, thank you very much, Rachel, and for the UICC, my dear friends, Your Highness. It is a pleasure to be here. I had the opportunity to be with you in Dublin, in Montreal, and now a long time ago, but whenever you are in health, your heart is always on health. So it is really a pleasure to be with you. Let me tell you that I would say that our biggest challenge, or two of our biggest challenge, were, one, how to move the system from a curative system The Mexican health system was created, as many other systems on the world, were created to cure people. But now with non-communicable diseases, you know that prevention have to be the top priority of the health systems. So how to move a system that was created for hospitals and clinic and medical units to the streets, that is a challenge. And specifically for cancer, how to do that on prevention. My colleague, Dr. Ahued, was talking about lifestyle habits, and we all know the typicals. But how do you pinpoint very important things on the well-being of a population that are easily to develop, well, very hard to develop, but that are low-hanging fruits that can really make a difference? For example, in terms of prevention, exclusive breastfeeding for a woman with a child. That really reduces the chances of a woman for a breast cancer. But we usually, when we talk about cancer, we don't talk about breastfeeding. We talk about breastfeeding for many other things, but not for cancer. So how do you pick up those special things that can make a difference in terms of prevention? Also in terms of prevention, Armando was talking about that. I had the opportunity to universalize the papilloma human virus vaccine for all the country. And it was a challenge, universalizing a vaccine. And let me say that Mexico has probably the most extent vaccination universal program on the world. And universalizing a vaccine is always a financial challenge. But when you make clear the message that there are things that are more important or that money can buy, you make your point and you develop the things. The other was early detection. Early detection, not only in Mexico, everywhere is a problem. And what we understood is it was not a problem of information. It was a formation problem. It was changing the abilities and capabilities for life in order for you to know that you are responsible for going every now and then to a facility, to touch yourself, to see what you have to do. Changing the mindset, and we had a lot of pilots on how to change the mindset was very important, and we have hard evaluation on how successful it was trying to change the mindset in order for you to take responsibility on what you have to do. And talking about the other big challenge, of course, is financing and the quality of curing. You can prevent a lot of things, but still you're gonna need to cure. And we have a demographic transition and we have an epidemiological transition. So we're gonna have to cure. How to finance a system? In Mexico, until 2003, only people that had Social Security to the laboral status had a financial system for their health. After 2003, we implement the so-called Seguro Popular, the popular insurance. And I know Felicia Noll is here. I haven't seen her, but well. But one of the challenges of the universal health coverage that started with the Seguro Popular was how to get people insured and then how to finance incrementally the things you have to finance. In terms of cancer, we have a catastrophic disease fund that when you have 1 million people in the insurance, you have some money of those 1 million people put by the government in order to finance a system. While the systems start growing, and now the Seguro Popular have 53 million people on the system, then you incrementally have to put money into different challenges. We started with cervical-uterine cancer, then breast cancer, then with the help of Dr. Alejandro, ahí está Alejandro, está distraído, pero bueno, with Alejandro Moar. We had all these studies in terms of knowing how should we prioritize and start financing different interventions. We start with all cancers for children under 18. We continue with prostatic cancer, testicular cancer, colon cancer, and we start introducing all cancers that were in a list of cancers, the most important to be put into the system. And let me give you one example of how, because sometimes we don't like to talk about money, no? But money is important. It is not the most important thing, but it is important. Before financing acute leukemia, lymphoblastic leukemia in children, in Mexico, 7 out of every 10 children died of leukemia because they abandoned treatment because they did not have money to pay the treatment. After we introduced the universal financing of all cancers in children, 7 out of every 10 children survive leukemia. There's there's a huge place to go still, but financing universally cancer, it's an important way to go, and we have to keep on telling leaders with examples how important it is. We're talking about life and death, so money has to be put there.
Thank you very much. So I was going to ask him to tell us, how is it that an economist is going to tell us about how to address health? And I think you have done that very nicely already, but I want to pull out a few of the economic things that you hinted at. You hinted at behavior. The problems of changing people's behavior sometimes seem insurmountable because, we all like that sweet stuff. We all like that stuff that's not so healthy for us, and we all pretty much don't want to exercise all the time. All of these things. And there's a lot about cities and countries that can change that behavior, but it's not so easy to do. So as an economist, you have, I think, already hinted at ways that we can use incentives, and Seguro Popular, I think, is one way. Of course, other things such as Mexico has done with taxes and sugar-sweetened beverages and so on, showing the leadership in using those tools of economics. And I think those are something you know very, very well. But also, as you said at the end, it's money's important, but it's not all about money. So recognizing that even a program for childhood leukemia, it might be expensive, but there are ways to make it possible. Mm-hmm. And I think you've done a very nice job of blending those things. I'm going to ask you to go off script a little bit, so forgive me. No. You've given us, and your colleague, Dr. Ahued, gave us some great examples of what has worked and what has been done because of the political will here. Can you give us one example of a mistake, something that hasn't worked, something that you tried, whether as Minister of Health or now in New Mexico City as Minister of Economic Development, that has been too much of a challenge or for some other reason has not worked? And I would have to say, I think that learning from failure is just as important as learning from success. So, any failure?
Of course, there are always failure in public policy. Public policy is not hard science. So you try things, you think you have all the evidence, you do the diagnosis. But at the end, the magic of public policy is implementation. And some of the time, implementation fails. And the secret, as you were saying, is to learn where did you fail in order to do it again or do it better. Let me tell you that, let me put you one example, and let me get out of cancer. Condoms, the usage of condoms. We were informing the youth how important it was to use a condom, how to put it, when you have to put it. And when we used to do surveys about how young people from 15 to 29 years of age knew why a condom was important, how to use it, when to use it, 99% of all young people, they knew how to use a condom. But then one out of every 3 women and 1 out of 2 men did not use a condom on their first sexual experience. What happens between the information and the action? So we were failing in only giving information. And again, the behavioral part, this part of making you responsible and not giving only you information, was a crucial part for many other policies that we implement. We thought that because in every hospital we used to put information on why breastfeeding was so important and was so important for your children and for you, and still we had 22% of exclusive breastfeeding in women. What was happening between the information and the action? And with those mistakes, because we were not impacting at the end, with those mistakes we learned that we should continue giving information, but that information has to be accompanied by other abilities. And if you don't change those abilities, no matter how much information you give, you are not going to change habits. And changing habits is something very, very, very hard.
It's a great example, even though it's not cancer. It's a great example. Information by itself, sometimes in public health, I think, we rely a lot on information, but we have to go beyond that as well. I'm going to ask you to stay. I'm going to invite our third guest up. Yes, please. Ms. Erin Barringer, who is a partner at Dalberg Global Development Advisors and an expert on health financing. And we're going to turn to our topic. Erin, Dr. Salomón Chertorivski, nice to see you. Have a seat. We're going to turn to the topic of financing. We've touched on it already a little bit. It's something that is near and dear to my heart. I think we all are aware that financing for NCDs, and including for cancer, is the elefante en la sala sometimes. It's very a challenge for us. We know many things that need to be done. We often know how to do them, though we need more implementation science and implementation itself to learn from the mistakes and the successes as well. But we often feel really stuck because the financing is not there. I've studied NCD financing from the donor community for many years. We know that donor financing for NCDs, which is not so relevant for Mexico because Mexico is a well-off country that takes care of itself well, but for many countries who need assistance, it's not there. Less than 3% of all donor financing for global health is going to non-communicable diseases, and just a fraction of that for cancer. And often what is being provided by donors for cancer is aimed at a tertiary level, aimed at specialized care. So there are some very big gaps. For domestic governments as well, you've been a minister of health. You know that health is not always the most favored ministry when it comes to the public budget allocations. And you know that there are a lot of challenges with how to spend the scarce resources. And you spoke also about priority setting, which is a favorite topic of mine. So I want to ask both of you to begin to address this question with you, and I think with us, and I think I'll turn to Ms. Barringer first, and ask if you can talk a little bit about the global perspective, and then we'll come back to the city. The global perspective that I just introduced on NCD financing and cancer financing in particular. What's the magnitude of the problem? And maybe one example of how you've seen it being effectively addressed. That's a big ask.
Yes, excellent. Thank you, Dr. Nugent, and it's great to be here with you and with Dr. Chertorivski. And many thanks to UICC and the sponsors for having me here today. We've heard a lot today about how large the need is for improved NCD treatment around the world and for cancer treatment specifically. And as you said, the question now is, how do we even think about financing that? And how much do we need to actually generate the improvements that we want to see, that all of us are here today to support? And so you can break down the gap in financing need for NCDs in many different ways. I'm going to start by talking just about one slice, which is infrastructure that's needed to treat NCDs. So we need tertiary hospitals, we need clinics, we need pathology labs. There's a whole list of infrastructure and equipment that a city or a country needs as it looks to treat NCDs and cancer. And the fact we have is that in order to reach WHO targets for health infrastructure, we need an estimated $600 billion invested in health infrastructure. That's a large number. And if we try to make that just the portion that's needed for NCDs, you could estimate roughly a third to a half based on NCD mortality today. So that's 200 to 300 million that we need, and I don't think we have right now. It's part of why we're all here today, that we need to catalyze and galvanize to start to build the health infrastructure to treat NCDs in the world. And as you touched on, I think it's important that we all recognize the shifting global health financing landscape that we now need to raise this financing in. And so while historically donor financing, or ODA, official development assistance, has been a large tranche of funding for global health work in low and middle income countries, although less so in Mexico, that kind of pot of financing is flattening, if not decreasing. So we have about $150 billion annually going into development assistance, but that's growing now at about 2% a year. So it's not going to actually open up a huge amount of additional financing for NCD infrastructure. So then we look to other sources of financing, and we start to think about, I think, first and foremost, domestic resources, which we've heard from many of our representatives from Mexico and from Mexico City today, how critical domestic resources have been to financing NCD prevention, treatment, care in Mexico. And the good news there is that kind of domestic resource pot is growing faster. So it's growing at about 7% annually, and it presents some exciting opportunities through some of the advocacy and policy work that you all were just discussing to actually start to try to direct some of that towards NCDs and towards cancer care. But there's a third pot of financing that I'm particularly excited about, and I don't want us to miss in this room, which is private investment. And I think what we've seen in recent years is private investment in low and middle income countries, I should say, and in health specifically, has begun to dwarf any official development assistance. And so most recently in 2015, private investment was 4 times as high as official development assistance. And that actually presents enormous opportunities, I think, for us in the NCD community, in cities, to start to think about how do we direct more of that private investment towards NCDs, towards NCD infrastructure, which is a natural entry point for private investment, and how do we also think about smart ways to actually blend private investment with domestic resources, with philanthropic capital, to catalyze greater financing for the NCD space.
Thank you, Ms. Barringer. I think that's a great way to sort of refer back to why we're all here, the Cancer Leaders Summit, and the support that is coming from different kinds of sources to mobilize this effort, because it's private, it's public, there's civil society involved, all different roles, all different ways. So I think that's it's all something that we are thinking about here at this meeting. I want to turn to Dr. Chertorivski, and having been at the national level and now economic development at the city level, okay? So health and economic development, maybe you want to say a word how, as an economic development leader and decision maker, where does health come into that? And then with the financing thinking, how do you at a city level raise your hand and say, hey, we're here, we need some financing. Who do you turn to, and what's been working for you?
Okay. Let me probably say 3 things. The first one is we need to change the narrative. I mean, health is not a cost. It is an investment. And I know many people try to have that speech, but we have to clearly set up the priorities and convince the financing ministries that it is really an investment. And for that, we have to create the numbers and the narrative. I mean, how much are you paying today? And what is going to be the social rate of return of that investment? In terms of economic development, having a healthy population for productivity is one of the most important things. So how can we, as societies, start speaking differently about the money that we are putting into health? It is an investment, and we have to take the decision that investing in health is the most important thing a city or a country can do for the future of its population. Second, I would say that we have to understand that the budget for health cannot be only at the health ministry. I mean, there are so many things on the social determinants of health that at the end are going to be crucial in terms of the impact that you can actually have on health that are really important. When you talk about, for example, in Mexico City, you have to talk about water and you have to talk about sewage. That may be much more important for health than many other measures that you can take inside the Ministry of Health. And we can talk about many examples. Even the law may be very important for that. How you convince the public in terms of doing so, I think it's very relevant. Let me also tell you, Rachel, that I believe in private financing, but if we really want to develop communities, countries have to take the responsibility of financing health. I mean, there's no way out if you want to be a community or a developed country. If you really want to be or to try to be a developed country, then a country financing its health system and putting any money needed in terms of having a healthy health system. I think if as communities we set priorities, that priority number one for a country that wants to be, again, a community. And a community, I understand it when you don't leave anyone aside, when you have really a country that cares about everyone. You have to understand how much that is going to cost, and you have to decide how you pay it with taxes and public financing for that. That doesn't mean that private investment cannot be important in particular ways, but the priority for health systems have to be public spending. And third and last, I would say there are limited resources for unlimited challenges. And I'm not only talking about money. When we talk about financing and planning the system, we have to think about specialists and physicians and nurses and beds. And I mean, we have limited resources, so we have to prioritize. And prioritizing is very, very difficult. But you have to make good cases and good efforts in order to prioritize and set the time challenge of how are you going to get into the system.
Thank you. That's really a great response. I think for any economist to be able to say, health is a great investment, and study after study we see that the returns on investing in health are very positive, up to 200 to 1 for tobacco control investments. I mean, there's no doubt, and there's no way out. Mr. Finance Minister, there's no way out. You need to have a healthy population to have economic development. I'm going to turn to the audience for maybe 1 or 2 questions. I know we are just about out of time, but wanted to give you a chance. Yes? Yes, in the back over here. The microphones are coming.
Thank you very much for giving us the opportunity. It's Waheed Kharousi from the Oman Cancer Association. First of all, I'd like to thank Mexico for being a perfect host and looking after us all. But I would like to ask the gentleman and also the previous speaker, Mexico has proven to be very supportive and political ally for cancer. I would like to know what role do you play with the civil societies who are very important in getting your messages and the messages of cancer to the population. I have not heard that being pointed out. Thank you.
Thank you. I think that question is yours, Dr. Chertorivski.
Thank you, Rahira. And here are a lot of people that represent the social groups and the civil society. I think in order to tackle cancer and for the care and control of cancer, probably the first most important thing is talking about cancer. And for talking loudly about cancer, there's no one that can do that better but civil society and organized civil society. And in Mexico, that has been the case. There are a lot of groups when there was no public financial for cancer, that they were already financing cancer for children, that they were already financing breast cancer, and now they are the most important allies of the government when the government starts financing the cancer. I think civil society, organized society, is a crucial and key element from the bottom to the top. First of all, speaking about cancer.
And we heard some great examples last night. You were with us of speaking out boldly and directly and personally about cancer. Yes, back here, please.
Okay. My name is Ronsi CW Chidebe, and I'm actually the Executive Director of Project Pinglu from Nigeria. I'm one of the UICC Young Leaders and also one of the UICC SPAC grantee. Dr. Salomón, I really thank you for your passion. But when you did your first opening, you mentioned that one of the challenges that you actually discovered was to move the health system from the curative system to a system that also incorporates prevention. This is very important in cancer care because over 14% of cancers, cannot be prevented. But I just wanted to understand, this challenge that you mentioned, is it still in existence or has it been mitigated? If yes, how? If no, just to share the insights so we can also learn. Thank you very much.
I'm going to turn this one to you, but I'm going to ask if somebody else in the audience has a question about innovative financing or financing examples that have worked. We'll maybe come to that to next for Ms. Barringer. Dr. We have one. Yes, we'll come back. Yes, please.
My name is Dr. Kelechi Eguzo. I'm also from Nigeria, one of UICC Young Leaders. I happen to be working in a Nigerian partnership to set up some cancer centers in southern Nigeria, and financing has been a big problem. So I'm keen to know how to access private sector financing as well as ODAs to be able to get the project moving forward. Thank you.
Perfect. I couldn't have planted that question better. Thank you. So we'll go first to Dr. Chertorivski again, and then Ms. Barringer.
Thank you very much. And first, an advertisement for people coming from outside. I hope you have time to visit Mexico City. I hope the organizer gives them time because we need, for the economic development, we need you to spend on restaurant, take some tequilas, have some fun in Mexico City. But no, let me tell you that it is an ongoing process. It is really very hard because most of, I would say all the health systems on the world have been creating to cure. And that was the ambition. So moving to curative to preventive, it's very, very hard. And I would say that the first important steps is how much budget do you allocate to prevention? Because usually the vast majority of the budget of a country, it is not the most economically smart way to go, but most of the budget of a health system is dedicated to curing, to hospitals, and it's very important. But we have left prevention with only small pieces of the budget. So the first important step towards really moving the system was moving the budget. And what we did, it was almost 10 years ago, it was we allocate at least 20% of all the federal budget had to be allocated to preventive policies. Second, we need to change the mindset of the professionals. We need to change the mindset of the doctors. So what we did was to change the percentage of the physician's specialist examination. In order to get to a specialty, most of the questions and the examination was dedicated to the very specialized things that a specialist have to know. But we changed the percentage of the test that had to do with prevention. So faculties in the country had to train physicians to prevention. Because if you don't have the professionals with a new mindset into prevention, that is almost very different, it is very hard to win. And the third thing is you have to think out of the box again. It is not only the health system. It is what you do on multiple variables that can change the reality. For example, in terms of non-communicable diseases, we had a huge problem on heart problems in Mexico. And one of the things was salt. And the vast majority of the salt consumption in the country came from white bread. So we had an agreement with the industry, and we took out 10% of the salt of the white bread in the country. That only measure is going to lower 30% hypertension on the next 10 years. And those measures, most of the time, are not part of the health system. You have to see them with the economic department, with the industrial department. You have to think out of the box in terms to move the system to the prevention.
Can I ask you, was that a voluntary agreement with the industry to reduce the salt, or was it with a heavier hand?
I would say it was, they agree on doing so, but you know the state is there.
They understood. You told it to them in a way they understood.
Yes.
Thank you. Ms. Barringer, can you speak to the gentleman's question here?
Yeah, of course, and thank you for the question. And before we dive into that, I want to come back to Dr. Chertorivski's point, which is, in an optimal world, I think you would look to state or municipal finances to fund most of NCD treatment. And there are tools out there, some of which we've heard about in the case of Mexico, like municipal bonds or like tax levies that really can help raise additional financing to go into NCDs. I think the Nigeria case actually is quite interesting because Nigeria is a country right now that, despite many efforts to increase their fiscal space and direct more investment to health, is not quite there yet. And so it sounds like what you're working on is more of a model that could attract private investment in this space where we don't yet have enough financing from the public sector going into NCDs. And it's exciting to hear about, and seeing entrepreneurs kind of investing in developing new models for NCD treatment is something that excites me enormously. And so I think one of the more innovative approaches we've seen is actually looking at business models that cross-subsidize care, because this means that you can create a financially viable and attractive business for investors but also still provide care to all income levels in society. And so this was a model that was piloted by, or that started by Aravind Eye Clinic in India. But actually there's one right here in Mexico, Sala Uno, which is, it's an eye clinic, so it's not entirely relevant to NCDs, but it's an eye treatment and surgical clinic that essentially provides care to all income levels, and that can charge higher amounts to higher income levels in order to get a private room, get a certain surgery time, and use that to subsidize treatment for lower income levels. And in the case of Sala Uno, they actually give surgeries free to 70% of their patients through this cross-subsidization model. And yet, they're still making a return, and they're still a viable private investment. And so they've managed to attract capital from local private investors and from international donors that kind of underwrite or subsidize some of the cost of the business. And so to you, I would say, I think that presents an incredibly exciting opportunity to explore, which is, can you start to develop this type of cross-subsidization scheme, this new business model within cancer treatment, and then use that to have a more compelling investment case to some of the private sector investors that we know, and I'm happy to share afterwards, are excited about this space.
Thanks. I'm gonna ask for a little more discussion before we go to the next question, because I'm really glad that you brought up the equity issue, the question of, yes, care can be provided, it is being provided in many cities and in countries, but often out of financial reach for the poor. And there is a public sector responsibility to reach everyone. But it's a big challenge. And so we have one example of this cross-subsidization that is a model, I think, still being tested in a lot of places. So I wanted to sort of take that example and see what your thoughts were about the either cross-subsidization or, how can the government increase access, achieve UHC, but perhaps help the poor reduce their out-of-pocket payments in ways that perhaps the wealthy are more willing to pay themselves to buy private care. What do you see as that tough balance that the public sector has to make?
And it is it is a huge challenge. We need to know that social determinants of health are crucial, and money is one of the most crucial things, not only here in the UK, in wherever you go. The richer people, sadly, are healthier. And in so unequal countries as ours, public budget has to particularly go in order to universalize the possibilities of quality access to the system. But again, I would say that in terms of national discussions, the priority has to be on how to create universal health coverage systems. That has to be the priority. The discussion, it is difficult, yes. There are a lot of budget restrictions, yes. But how are you going to incrementally advance towards universal health coverage systems? That has to be the way to go. There's no way back. And that has to be the narrative and has to be the spirit. Of course, when you have leaders that understand that priority, things are easier. As my colleague was saying, Miguel Ángel Mancera, the mayor of this city, he is really a health champion. He's really into health. He's really into budget for the health system. Not only that, let me tell you that our national constitution has protection for health as a human right. Well, our local constitution that we just wrote it for the first time in our history this year has not protection for health, has health as a human right. And that was the political leadership of Miguel Ángel Mancera creating a new system. We need leaders, and we need to advance into a publicly financed system, and only universal health coverage can give access, more equal access to the unequal population. I think that should and have to be the priority without, again, and really, Erin, without minimizing the private efforts that can be there. Health has to be publicly financed. I don't have any doubt about it, and we have to tell guys like President Trump that he doesn't care about the universal healthcare system, how wrong it is, not only for the well-being of the population. If he cares about his economic system, how important it is for the economic system to publicly finance health for all.
I was just going to say quickly. I could not agree more, and I think Mexico, especially with Seguro Popular, has been such an example of how, it's an example I use all the time, of how you have created a health safety net for the lowest income populations in the country while creating universal health coverage. And probably the question to other countries and to us in this room is, as we build universal health coverage, how do we build that for cancer? What is that basic package? Now many countries have universal coverage for maternal and child health care. What do we add on to that so that we can start to layer this in a piecemeal and realistic way, and help show countries that path, similar to how Mexico has achieved it?
That was really important. And again, there's Dr. Moar and Meneses and all that team of the National Institute of Cancer here in Mexico. They were the key players on how to incrementally start financing different types of cancer. And they did the scientific medical case for each cancer. And then Alejandro Moar, he came with me, he used to came, now we need to finance no-Hodgkin lymphoma. Why? Because the overlife is going to be this, and because we have already oncologists all over the country that can give, and the drugs are already available, and we can do it. So run your numbers. So I start running the numbers, and I do all the mathematical, and we go back and we say, we can universally finance non-Hodgkin lymphoma. And then he came and testicular cancer. Okay, let's see. And then, for breast cancer, there's a new drug that if the woman has a HER2 positive gene, then she needs this drug, and it's 30% more expensive, but the overlife is 40% more. And I say, can we finance that? Yes, we can finance that. So it is incrementally. And we need to know that there's no one health system in the world still that can finance everything for everyone. So we need to take decisions. And I believe that in cancer, there is a very clear roadmap over which cancers should be prioritizing and how can you cover them and approach them. And if you do that on a timely manner, I think at the end you're going to have more, probably 80-85% of all cancers covered. And I believe every financial country system can support at least 85% of all the cancers in a country.
That's a very inspiring and a very exciting message coming from the one with the economic hat on, which is great. I think we have a question over here. It might be our last question. Speaking of the medical and scientific case, yes.
So thank you for, Mary Gospodarich, past president of UICC. Thank you for a very rich discussion, and it's very good. But even if tomorrow somebody financed all the cancer care in the world, the progress to scale up services would take a long time. So I'd like you, Salomón, and maybe the other lady, to talk about the role of research and innovation, and not only the research innovations done in Harvard and in Oxford and in Canada and Europe, but also in the rest of the world. and the role of a private sector and also ministries of health to actually finance research and innovation to improve the value for the money of the healthcare and cancer care.
Great. There's always a role for more research, and it's a tension between delivering care sometimes and doing more research to get better care later on.
Exactly. I know whatever Mary says, she's always right. So she's always right, really. No, of course. And moreover, now with such a personalized medical scientific possibilities, with genetics, and understanding the differences between regions and between the genomic map of every region, we need to do the research locally, because we are not going to be able to import everything that has been learned in other places. So we need to have more people doing research locally, and we need to put money into research. Because, I mean, we are living that crucial moment, at least I know in Mexico we're living that crucial moment in which we could have the first generation with a life expectancy lower than the previous one. And that would be the first time in our history, not only as country, but as humanity. But at the same time, we are living the specific moment in which we probably can jump to a life expectancy of 150 years. The difference in tackling non-communicable diseases, which has to do much more with prevention, but to jump into the fantastic possibilities that the medical science can offer humanity is research. And research that has to be local. And yet we have a huge challenge because the money that we put into research, it's still very, very low, Mary.
Wonderful, thank you. Our time is up. I'm going to give a very quick wrap up because I chose to take more questions instead of spending so much time. First, I want to thank our guest, Dr. Ahued, who was with us, Dr. Chertorivski, Ms. Barringer, fantastic discussion. A few things I think that we've heard very clearly, and I want to pinpoint one that is clearly successful both in Mexico City, I think also in your country, which is that when you have an open dialogue between the public and the politicians, that trust develops. And so when you have to make those hard decisions and you have to make those choices and think about what comes now, but other things can come later, that trust seems to be there and people accept it. And that is really very profound. I must say we can do much better learning that kind of lesson north of the border, so we welcome your help. I also would like to say that I think we've seen a beautiful marriage of what we know from economics and behavior change, something that Sir George Elaine brought up at a session this morning about, understanding better how to alter people's behavior. And we've heard some good examples of nudges. For instance, the exam for specialists, to change the questions on the exam to motivate the specialists to understand better how to deliver preventive care and to know better their patients in order to do that. That's tremendous, and it's right in front of us, but it has to be thought about in that way. And I think also some nice examples about financing, blended financing, but then I think the paramount importance of the public sector. Again, that the public can trust the public sector when the public sector takes on that responsibility of health. And then finally, that the economic case is there. It's not only there, it's compelling. And that the economic case then pulls the financing along with it. And we see more and more examples of that. So I think with cancer and the City Cancer Challenge, we will look forward to even more examples. Thank you again, and thank you to the audience.
Thank you.